All right, so to our lecture, understanding the immunology of HIV, how this affects infections and care in the human host. I want to go over a little about the epidemiology of HIV and how it affects your patient care and prevention efforts, and also want to understand the basic clinical care tenets of HIV care and prevention. So probably many of you remember or have heard about this. Did anybody want to volunteer kind of what this was in DC? Well, that's a great good point. So this was at the early days of the HIV epidemic. So in about, I would say the late 80s, there was not a lot of drug development for HIV. It was really causing a lot of deaths. We didn't have treatments at that time. Why am I showing you this? This is the AIDS. So this was a movement in the United States to bring attention to the need to look for AIDS and HIV treatments, but also to each quilt actually represents a person. And so remember, this was the leading cause of death for adults 25 to 44 years in the United States in 1995. So this was really a big viral killer in the United States. And you'll probably read, and Dr. Morano has done great lectures on this, the history of HIV and AIDS activism. Trying to get drugs to market really opened up the clinical trials world. The science that was developed for HIV antiretrovirals was actually carried to hepatitis C antiretrovirals. So the science, the activism, the clinical trials emphasis through the HIV treatment movement has really shaped infectious diseases. And we're still working with those tenets that were developed there and bringing them forward for other disease states. Even COVID, to some extent, uses some of that technology that we learned studying the HIV virus. So what is a retrovirus, right? So it's in the lentivirus family. So it's a retrovirus because it's an RNA to DNA virus. So HIV is part of those that virus family. And you'll see there's HIV-1 and HIV-2. Why is that important? Many of you probably already know there were actually distinct transmissions of HIV and HIV-2, 1 and 2, throughout human and non-human primate evolution. So what we're seeing is that you've probably heard of feline immunodeficiency virus, right? FIV. There's SIV, simian immunodeficiency virus. And through non-human primate and human interaction, through use of primates for food, interaction with primates, the virus actually jumped from non-human primates to humans. And we think this actually started happening in the 1900s, but again, kind of taking a page from the COVID handbook, right? As you have more, if you have more animal and human interactions and habitats disappear, specifically in sub-Saharan Africa with the onset of transits and highways, people really started interacting with other people more often. And so, as you can imagine, we had more viral transmission than human to human. So it accelerated. And as you probably know, it actually accelerated further in the 1980s with airplanes and travel, et cetera. So you're seeing here transmission. This is actually pretty, I think, important to know from virus transmission. We see this, they're called clades. You can see transmission even between groups of people, HIV transmission, and you can track actually that interestingly as well. But we're seeing this here. Does anybody remember the difference here between HIV-1 and HIV-2? HIV-1 actually had 3 separate transmissions, if you can believe it. That's why we have 3 groups, M, N, and O. And then HIV-2 actually had 2 separate. So we were talking about 5 separate transmissions. So this, unfortunately, was happening on the ground. And so what we're seeing here, you probably know HIV-2 is considered milder, but it's still immunodeficient. You can't use some meds there, but still very important to screen for. And I'm going to interrupt this commercial message for our wonderful Carrie Wilsinski. Carrie, welcome for those online. Carrie Wilsinski is our wonderful nurse practitioner. Do you want to introduce yourself? You're an amazing individual and hold our program together.
Yeah, I've been vaccinated because my kids have been super sick, fluid struck, so
Sure.
I'm getting over my own thing. Anyway. So, but I've been at the VA for about 12 years. Before I was a nurse on 7 North, which is now on this floor, respiratory. And then I transitioned 4 years ago over to APRN in the ID section. So clinical navigator and nurse practitioner there. So I mostly see patients and the telehealth platform with Dr. Morano, but I'm also over in the clinic. We do PrEP on Wednesdays. I help cover Dr. Vega. And then there's the anal PAP clinic now, which I help out with too. And then we see all the patients and then medical sector. So.
It's amazing. So Carrie is our COVID nurse warrior. So she was nurse manager during the epidemic. So she was really holding the fort together. And we were so lucky to recruit her to ID. She has spearheaded our in cytology screening, which was part of your work with ID Week. And then also has really shown, how do I say, fortitude and courage and conscientiousness with our prep navigation, making sure everybody's getting into care, and has really been a wonderful boon. And she will be in contact with you along with Dr. Morano, if there are things going on as well. So thank you, Carrie, for coming. So we were just talking about HIV-1 and HIV-2. What you need to know from an ID current standpoint is, again, a kind of COVID similarities, right? All viruses usually have markers, and this is how our HIV antibody antigen test works. Now, back in the bad old days, we had to do separate tests for HIV-1 and HIV-2. Thankfully, one test does it all, right? So this is a very, very good generation test. You can target it. It has very, very good sensitivity and specificity. And we're looking for that P24 antigen. Why is that important? Well, you'll probably hear about rapid tests, serological tests, et cetera. Many of them are still very, very excellent. And so this is what you're looking for. Now, what you need to know about the virus? What you need to know is, I think, with any virus, right? Any infectious disease, any bacteria, how is it creating disease in the host, right? So viruses typically will dock, right? Like a docking station. They'll find receptors. They'll actually open up that pathway. They'll empty their viral contents, and they'll start replicating. They basically just take over that replication machinery of the cell. Right. So that is COVID, that's HIV, that's hepatitis B. So it's very similar. Now, the thing that makes HIV different, it's a lentavirus, right? Lenta, slow in Latin. So people can have HIV but not show symptoms and therefore can transmit HIV and get sicker themselves. So you'll see this is a little bit, why is this important? Well, the drugs that we have, right, are working on specific mechanisms. So infectious diseases has really evolved to become targeted. We used to use broadly acting antivirals, right, like ribavirin and interferon, right, for Hep C, which would cause all these side effects. Why? Because they weren't specific to a receptor. These are specific. So that's why I wanted to bring these out. This is the actual specific part of the HIV. I probably remember Timothy Brown, right, the HIV cure. He was transplanted, right, with cells that did not have receptors that the HIV could attach to. So that was a really nice, step forward to cure research, right? How can we either block these receptors or create some kind of mechanism, maybe a broadly neutralizing antibody, something that can block these receptors and does not allow the HIV to dock, right? So how can you think about that practically? This is a really nice schemata. What you could see, and I'm going to go through it kind of in order, fusion inhibitors, so stopping the HIV virus from fusing, right? That would cause actually a lot of side effects, you can imagine, because it's in the body, it's not in the cell. So it was thought of and it was developed, but it hasn't really been used. What's really been important and what you're going to see in clinic are your non-nucleotide reverse transcriptide inhibitors and your nucleotide reverse transcriptide inhibitors. These are really your bread and butter of your HIV meds. Why? Because it's stopping those nucleotides from going into the virus, right? So those building blocks we learned in medical school, where you have the guanine and the thymine and all this, it's stopping all of that. Integrase inhibitors are really a game changer for HIV care. It stops the integration, right, of the HIV into the genome. Why is that important? Well, because you're eliminating some of the latency, right, and the reservoirs of the HIV virus. And they're very targeted and they generally cause less side effects, right? Protease inhibitors are one of the earlier medications. Protease, right, it inhibits the protease from making those proteins for that virus regeneration. Maturation inhibitors, it has been developed, but as you can imagine, not as successful as these intracellular drugs. These are extra kind of cellular actors as much. So we have these, but these are not as effective. So what are we thinking about HIV? HIV not only destroys the immune system, right, because it targets the CD4 cells, destroys them, but it also can establish latency. So you'll see throughout your ID career, you'll probably see articles on CNS latency, lymphatic latency. How do we flush the reservoirs, right, to affect an HIV cure? There's a lot of work on that. But this is the basics I wanted to share with you, because even with perfect virological control, there is still some latency. There's still some reservoirs that the virus can resurge and still causes inflammation. That's why we have high all types of cancers, and in many sense of people living with HIV. There are many types of cancers, lymphoma certainly, but other types. So we see the cellular response as T cells, but also remember B cells and humoral cells. So many of you are familiar with this, but I wanted to go over it because when you're thinking about testing or talking to your patients, remember, like all viruses, right, you have an acute, right, and a convalescent phase. Your acute phase, technically, well, they even call it eclipse phase, but what we think about technically is your short duration, right? 2 to 4 weeks, the acute HIV, right? So you think about rash, you think about sometimes shortness of breath, you think about fever, which also, if they have COVID at the same time, right, is a little difficult. We had that during the COVID epidemic, but certainly that virus, that acute, and then the set point. So why is this important? Your patient may or may not have symptoms when they're infected with HIV. In fact, many of our patients don't. Classically, they do, but many don't. And then you have a set point where the body is really trying to stabilize what is going on. And this, I think, is also helpful, is that the CD4 counts will stay high, but it's going to go down, unfortunately, unless there's a long-term non-progressor, right, or an elite controller. Those are very small subsets of the population who have basically, we think, a chronic inflammatory state. They usually have diabetes and heart problems as well, but that inflammatory state is also preventing, ironically, HIV progression. So this is what we do from HIV treatment, right? The goal of, as you can imagine, would be to treat the HIV to stop the replication. But sometimes you'll see in your clinic work resistance, right? When patients are not taking their medicines. Now, why am I addressing this here? There's something called wild type HIV. So if someone is newly diagnosed, it's considered wild type, right? It could be 1, 2, or 3 even strains, but usually it's one strain. And then if someone takes medicine, we expect that this to go away completely. The integrase inhibitors usually an undetected viral load, maybe in 2 weeks, 2 to 3 weeks. But then if this person, and we've seen this, take it once a week, or on weekdays only, or they get confused and they don't take it the way they're supposed to. The other HIV strains, it's a very highly mutatable virus, will start taking over. And this is where, and Dr. Morano will be your champion to guide you, but this is where you repeat the genotype, and this is how you find out what's going on with the HIV virus. Okay. Any questions on that before? I know it's a lot, but it's okay. It's all good. So this was actually an animation. And then this is overwhelming. So let me go through it one by one. This actually is beautiful animation. So we'll have to do an animation sometime, but let me just, I don't know if you can see my pointer. Yes. Okay. And I might just stand up and go through here, but basically this is a really nice schemata. My mind works with kind of mind mapping and associations. I'm kind of a group person in terms of brainstorming and mapping. So I wanted to go over this because, just bear with me, I think it's worth going through. Zidovudine on the bottom, AZT, was that first medication that came out that was active against HIV. Does anybody remember what that was originally for? Kind of a fun fact, but it was actually a cancer medication. So at Moffitt, it's still used for T-cell lymphomas. There was actually a drug up at Yale. The auditorium that I studied for and presented actually was, believe it or not, funded by distributing at AZT. So AZT was that drug up in Connecticut that was found, taken off the shelf literally, and found to be effective. Now, does it have side effects? Yes, it will increase MCV. It's not benign. But that combined with your lamivudine, that was the second one. Remember, these are your NNRTI. So this is actually why that's what they're interfering with. And so this was called Comavir. This is the brand. That worked out for a long time. Then came on the market tenofovir and then emtricitabine. Those were very, very effective. And together they were called Truvada or TA. It's called Descovy. Why is that important? These are kind of your backbone, if you will, and into our backbone of your HIV therapy. Why? Because it's interrupting that nucleotide connection. So in abacavir, we don't use much anymore, but we take an HLA-5701 genetic screen, and the VA even ask permission for it. We don't use it much anymore, but that's also good. So that's kind of how those went. Also, in the early days, we had protease inhibitors. These are the ones we use now. There are some historic PIs like tidanosine and cidabudine. They call them the D drugs, the D for dangerous and detrimental to health. Thankfully, we don't use those anymore. Endovir, that boards always like to ask about kidney buildup with adenovir. We don't use those anymore, thankfully. The protease inhibitors you'll see are darunavir, atazanavir, ritonavir, and we boost them, right, with other PIs. We noticed that ritonavir wasn't that effective by itself, but when you actually do pharmacokinetic boosting, it actually is very effective. So those are the boosters there that we use. Now, I just want to move on here. These are the NNRTIs. So the original one you probably heard, basically efavirenz caused, nightmares or manic dreams. So we don't use that much anymore. But nevirapine was also used in perinatal prophylaxis and was an early NNRTI. Traverine. Interestingly, ripivirine and doravirine were developed to overcome, and this is a very logical progression of how the science works. It wasn't just a hit and miss, it was actually designed to overcome resistances in efavirenz and nevirapine. So your ripivirine and your doravirine, right? So you'll get another lecture on resistances, but you'll see that those are different in terms of what resistances normally develop. So that way you have other therapies. Our friends, the integrase inhibitors, also called INSTIs for short. This is phenomenal. The binding capacity of the INSTIs are so great that we actually were able, this liberated us to do a 2-drug regimen. So many of you have seen the Cabenuva injections, right? Those use the cabotegravir and the ripivirine in injection form. Why can we use those? Because the cabotegravir is so effective, right? So we've moved on now to this 3-drug regimen. And believe me, they did 2-drug regimens in the early days. They weren't as effective, but now with this class, we have them. Valtegravir, Biktarvy, right? You'll see a lot of Biktarvy. That's your TAFFTC, Biktarvy. Jemboy is an older drug, but it still is very effective. It has that covacistin, but you have to be worried about pharmacokinetics. And then dolutegravir, which is great. A really good drug. You can combine dolutegravir with ripivirine. Brand name is Juluca. Very effective for people who don't have hepatitis B. Right? Because remember, your hepatitis B active agents are your tenafavirs, right? Those are really the mainstay. Some lamivudine has some effectiveness, but really tenofovir is what you need to have people on if they're at risk for recurrence of hepatitis B or have a core antibody if you're worried about them recurring. These are the entry inhibitors. Remember we talked about they existed, but they weren't very helpful. Viravirant, Patensavir, and Fugaride. Fusion was an injection. It was very difficult, very painful. Viravirant, you have to have a certain tropism for that. And we don't really use monoclonal antibodies unless someone's really resistant. And then lenacapavir, which is wonderful. This is a capsid inhibitor. And then we're looking at that not only for treatment, but also for. So I know that was a lot. Do you have any questions on that before I move? You will see that again and again. Don't worry. I just wanted to lay that out there. And Dr. Rapardo has all the copies of the slides, so she can share. And then we have the animations as well. So you'll also learn in clinic primary prophylaxis. Why? So folks who don't have T cells can't protect themselves against certain diseases. Certainly cancers, lymphoma, Kaposi's sarcoma, which is like a purplish growth. But certainly you've probably heard of pneumocystis jirovecii or jirovecii, however you want to say it. But we're talking about less than 200 or less than 14%. Why is that important? Well, people can actually present with pneumocystis pneumonia. You can have pneumocystis and COVID we've seen during the pandemic. And then just to know for your own knowledge, you can use Bactrim, you can use Dapsone, you can use atovaquone. Remember, Bactrim long-term can cause renal problems, right? And bone marrow suppression. We normally use 1 double strength a day, but you have some options. If you really want to be fancy, you can check a G6PD activity level. We don't routinely do that, but sometimes it's helpful if you're worried. We don't really use aerosol pentamidine anymore. You see that sometimes at Moffitt, but we don't use that mostly for HIV because it doesn't penetrate the entire lung. So we used to prophylax, you'll probably see in the literature, less than 50 cells per milliliter cubed with azithromycin weekly to prevent MAC, Mycobacterium avium complex infection. But that guideline actually went away a few years ago because our antiretrovirals now are so effective And we're actually testing and treating at earlier times. So our incidences of MAC, both in the blood and in the lungs, are so low now, thankfully, that recommendation actually went away, because people will just skyrocket through their CD4 count. And by the time you put them on azithromycin and you check them 3 months later, their CD4 count is, already 150 or 200. So that was really a nice change for guidelines. Anybody know, because the annotations didn't have his name, but anybody know the story of Ryan White? Okay. This is really important. So this was a gentleman who was born in 1971 with hemophilia A. And he needed factor VIII transfusions. And at the time, I almost fell off my chair when I learned this first time, but U.S. blood supply was actually not screened for hepatitis B until 1969 to 1972. It became mandatory. Hepatitis C, all the way 1990 to 1992, it became mandatory. And HIV until 1985. Of course, we had to find the virus first to be able to screen for it. So what my point is that they actually went back and looked at the Red Cross blood supplies, and they found that hepatitis B actually was in the blood supply, and you could see that trend. And so this gentleman actually contracted HIV through a factor VIII transfusion. As you can imagine, there was a lot of stigma during that time. He's shown in his school, he had a fight to get to go to school. There was so much stigma, and he was the victim of a lot of discrimination, and how to really fight to spread the word that HIV should not be a stigmatizing condition. Why do I bring him up? Well, the Florida Department of Health is a Ryan White Care Center. And so when you're at the Florida Department of Health, you'll be working with the Ryan White guidelines and also their standards of care. And this is a big, big lifeline for community folks living with HIV. It funds Florida Department of Health clinics, AIDS care, a lot of AIDS clinics nationally. And it really helps with the continuity of care for HIV. So there should not be anyone in the United States without care, veteran or non-veteran. That's why I'm bringing this up. The VA has a national ART formulary, and the Florida Department of Health has a AIDS drug assistance program. So again, nobody should be without beds in the United States. So this is ending the HIV epidemic. Why is this important? We're part of that. So St. Tampa and St. Petersburg, unfortunately, is right there. And why am I bringing that up? Because you'll get good experience with HIV, but also hopefully you'll be able to continue the end of the epidemic movement with your good care and your good problem solving skills to really become those ending HIV warriors on the front line. We're hoping, Dr. Morano, myself, that we will end HIV by the time we're 92 and hobbling around and giving lectures. So I think that would be lovely. We are trying to work on more vaccines and more cures. But right now, we're just trying to really get the word out for treatment and prevention. This is also, I think, an important slide, and this is actually accessed in 2023, but it's pretty similar. You'll see Florida, unfortunately, is a hotspot. There's several reasons for that, population being one of them, but also trying to get people linked to care and continuity of care. And why is this important? Well, because this does affect your IV practice. No matter what you go into, you're going to need to know about HIV. It'll be on your boards. I think it used to be up to 14% of your board. So it's important to your learning. And it's also important to your problem solving. You'll notice that some of the most important scholars of HIV actually became some of the most prominent COVID researchers, because it's the same kind of area of expertise with viral investigations and epidemiology. So why is HIV important? Well, it really affects people in the prime of their life, right? They're having relationships, they're probably getting exposed. And so you see this in Florida and also nationally in the community, is that it's really affecting young people. Why is that important? Well, if they go on to have children, et cetera, you have to make sure certainly not only their health, but the health of other people. And then also we do know, like many infectious diseases, affects sociodemographic groups disproportionately. So also in terms of your care and messaging. So the VA was interestingly one of the first pioneers of HIV treatment. Some of the early antiretrovirals were developed and given out at Walter Reed. A lot of the Department of Defense money had been helping NIH, obviously funding. So it's really been, I think, a very successful journey in terms of getting cures, doing trials, working with that. Now, why is this important? Well, when you're in your VA system, you'll be part of this largest network caring for veterans living in HIV. And there's certainly a lot of public health data, but there's also, I think, the practical nature of how do you take care of someone living with HIV efficiently, and obviously with a good heart, but also making sure that you're checking all the boxes in terms of making sure that they're getting the care they need. So why are we here? So we have the largest HIV prevalence in the entire VA system. So that's Miami, Orlando, Jacksonville, and then Tampa Bay Pines. Those are the main ones in our area. And so we have an older demographic here at the VA. Two reasons. One, we've been taking care of our veterans for a long time. And I think to credit that we're doing a good job, we're keeping them in good health for a long time. We have mental health, we have primary care. So you'll see, in terms of contrast to the community, you'll see a younger, usually demographic community. You'll see an older demographic, generally speaking, in VA, at least in terms of community public services and VA services. We actually have a proportionate distribution. So we actually looked at the data a year ago, and it looked like actually our viral load suppression rates across sociodemographics were actually comparable, which is, I think, a testament, again, to equitable care and equitable linkage to care. So I think that's certainly a testament to the VA, but also you'll see on the Ryan White end, the Florida Department of Health does a very good job with viral load suppression as well. So you'll see those work out very well. And this is also another demographic you'll be running into, both at the Department of Health and here, people who inject drugs. There's a lot more resources for folks these days, and so we'll get into that. But you'll have referrals that you can facilitate with your team, et cetera. But that's also HIV transmission risk. So what someone had said, treatment is prevention, U equals U, right? Undetectable is untransmittable. This is treatment is prevention. So this was in 2011. And basically they're saying if you treat somebody early on, not only does it help the person, of course, but it also prevents transmission. And so what we like to think in VA and the Department of Health, there's no wrong door, right? So there's HIV prevention and there's HIV care. So when you're seeing somebody for syphilis or for an STI, your next question is, how about PrEP, right? Would you like to think about HIV prevention, right? So as an ID doc, you're going to be really, I call them super internal medicine doctors, right? Because you not only have internal medicine down, and I know you'll be taking your board shortly, but you're probably one of the specialties we're really thinking two major questions: why and how to prevent, right? So, cryptococcus. Why did someone get cryptococcus? HIV. What were the things we could have prevented to get HIV? But then also the next step: how do we prevent complications? How do we prevent other infections, right? So we're trying to be proactive with our care in terms of infectious diseases. Something also important. These are all the continuums to think about. So when you have someone in your clinic who might be a candidate for PrEP or even travel clinic, right? You want to say, hey, have you thought about these things and think about prevention with them? And this is PrEP. So this is the HIV prevention slide. Has been very successful in the United States. They're pushing for a national community PrEP program. Thankfully, the VA already has a national PrEP program, right? So Carrie's done amazing work with this. Traveling vets. So no matter where a veteran goes, we can actually mail them medications, and we can actually, it's a little bit of, somersaults, but we do it, right? We get their labs at another VA, and we're able to see it. If they're based in here, if they're based in Tampa, then we can help support them. Obviously, if they're moving somewhere else, we try to get them into care somewhere else. But this is a really great network. And, we can see each veteran's information in the VA system. So it's really exceptional, I think, in terms of linkage to care, and arguably one of the largest PrEP networks nationally. And this is our PrEP numbers. Modest but growing, but certainly making an impact in terms of prevention. And you'll probably see, this is a little bit of history too. We had in the early days, PrEP, we weren't sure, was effective. Now we know it's up to 95. Now this says 86, but it's up to almost, adherence is about almost 100% effective. So transmission is up to 99% if PrEP is taken as directed, and this is oral PrEP, and then injection drug use at least 74%, right? So that's really, really, really good. Just a little bit, just to know, and I'm just going to gloss over this because you're going to get wonderful lectures on this. Just for your first day in clinic, I want you to be prepared. You have 3 types of PrEP now. Oral PrEP, which is your tenofovir emtricitabine or tenofovir alafetamide emtricitabine, and then your cabotegravir injection, which is our Aperture clinic. So we're excited to be able to offer all 3 of those. Your patients sometimes have preferences for either one. There are pluses and minuses of all of those. But it's certainly many options, and hopefully coming soon like lenacapavir. And this is similar. I mean, we're basically seeing people every 3 months. We're screening them for the basics, hepatitis A, B, and C, looking at their renal function. I check quantiferin gold because we have a high incidence of latent tuberculosis in Florida. But just checking your viral load, your antibody, antibody for sure. Your viral load you have to really check before you start cabotegravir. Some people will check a viral load if you're worried about a high exposure or a high risk exposure, either starting or during oral PrEP as well. Just cutting to the chase, TDF is extracellular, so you're worried about your bone and renal functions. TAF is intracellular, so you're worried more about lipids and metabolic abnormalities. Right now, your cisgendered women are really only able to get TDF, but hopefully we'll see the science changing there as well. And cabotegravir, you'll learn more in detail, but with any injectable, you have to make sure that they're following through and that you don't have the tail, right? So once they're off the cabotegravir maintenance, then you have to put them on something else if they're still at risk. And this is just a little about discontinuing PrEP, but don't worry about that now. And this is just a little bit more about PrEP. So getting ready for clinic day, just a few pearls here. So certainly you want to think about the science, but you also just be reassured your clinic note templates have been engineered very thoughtfully. And Dr. Borpardo's made some wonderful updates. So thank you, Dr. Borpardo, for your notes. Why is that important? Well, it's designed, and I did this as a fellow too. When you're learning HIV, there are certain things you're training your brain to look for. And so it's helpful to kind of go through it, at least in the initial stages and during your training, to really understand that everything is being taken care of. That's also helpful when other providers start seeing your patients who may not know them, right? So it's really helpful and it's efficient, actually. We've all been there looking for hepatitis B status, right? But if it's right on the note, then you're good. And linkage to care. So when you see someone and they don't show up in HIV world, right, that usually means they're probably having some kind of crisis, right? So usually we, want to get them back into the care. Obviously, we always do. And so what we encourage folks to do is to certainly write a little no-show note, maybe a little review and say, hey, let's get them back to clinic. And Carrie and Dr. Pardo are very good about this, but we notice this in the health department space too. Sometimes your folks who don't show up to clinic are the ones who need the care most. So just make sure that you are attuned to that. They need refills, they need labs. So some things to make your life easier. A few years we instituted these helpful order sets. And so I think this will help expedite your care so you can focus on the science and the patient and less on the mechanics. So this is your order sets. Maybe you're familiar with this infectious disease order. You do PrEP, there's HIV, there's STI, and there's NPEP, which now emergency doctors should be able to facilitate that as well. Why is this interesting? Well, you have the HIV viral load in the VA space. We usually take them every 6 months. Why? Because usually our folks have a lot of comorbidities. They're older. There's things that we follow up on. Technically, sometimes in the community, if it's a very high functioning patient, it's every year. But we found that, right, Carrie, we find that we always uncover something that needs to be taken care of. So we've really stuck to every 6 months. And you'll find that you, as ID doctors and also VA providers, you're also advocates for your patients living with HIV. And so sometimes it takes your, expertise and the weight of your title sometimes to kind of move that to the next step for that referral or for something they need. So essentially, HIV viral load CD4 count in the VA includes CBC, complete blood count, and your CD4 count. So when I'm ordering it, I always check if the primary care has done a CBC independently, and I just make sure I'm not repeating that as well. I'll just add on that and then just politely decline their CBC and let them know that I've added on it. Sometimes you can even alert them too. So basically, why is this important? Fasting lipid profile. We're not the primary care doctors, absolutely not, but sometimes sometimes if you feel like, it's missing, you can suggest it to the PCP. Sometimes I go a little bit rogue and I order it myself because it is guidelines now for HIV that you have to manage their lipids, particularly if they're on an integrase inhibitor. It's very important. So if it's been like 3 years, then I kind of just add it in there for their labs, but usually it's up to date. Why is it important to check hepatitis A, B, and C? Interestingly, in the military, you'll see a lot of vaccines, anthrax, smallpox, oh my goodness, live polio, right? But you sometimes don't see HPV, right? Human papillomavirus vaccine. And sometimes in our generation that missed the hepatitis B vaccine as a child or an infant, sometimes you still don't see hepatitis B vaccinations. Unreal, right? But it happens. So you really want to check and double check that immunity to hepatitis A and B, and obviously screen them appropriately for hepatitis C. STI testing, just clinical pearls. Some of your veterans will not be in any relationships, and that's fine. The Ryan White guidelines are really yearly. It's pretty strict. So you do want to add those in. Extra urinary is up to your discretion. And Dr. Pardo will give you all of the information on that. But we have wonderful nurses who will be able to help facilitate that through nursing intervention. And then quantiferon gold is important, I think, every year, no matter who you're seeing for HIV. What's important? DEXA scan. I would go for it if they're above 50 years old. Remember, the PCP will be managing the colonoscopy. That's age 45. Anal pap cytology, we have picked up, thanks to Carrie's great work and Dr. Mapardo's great work in clinic, early cancers. This is a real thing, actually. This is very disfiguring and very difficult for patients. So it is important that we screen. It doesn't have to be yearly per se, but at least getting a baseline and screening based on what those results are. And then your handy vaccines, which is helpful. So the VA has made it. I would still use your guidelines and your baseline knowledge, but we have some options here as well. So prep care, similar, but I think the only thing I wanted to add is that we're offering Opportunistic, which is a pharmacy request and a screen. Similar labs, right? So you're doing similar labs here. And we do, in special cases, we do screen for other types of STIs as well, but just talk to your attending about that. And this is our STI menu. So we've made this available to primary care as well. It gives you your testing, and then it also gives you treatment guidelines. So hopefully it will help kind of expedite your treatment so you can focus on the patient and getting them better, and not having to hunt and peck as we all used to do to figure out, okay, what formulation of penicillin and all of this, make sure I write it correctly. So hopefully it'll reduce medication confusion as well. And this is our harm reduction menu. So you'll hear more about it, but just briefly, many of your veterans, especially if you're seeing them for Hep C and sometimes for HIV, will be actively using IV drugs. And that's just unfortunately the reality of the world. But what we can do in VA, which I think is wonderful, is we can either the primary care, or if you're feeling ambitious and your attending's okay, a SUDS outpatient consult right then and there. There's also walk-in hours for your patient. We do give out kits. These are national SSP kits. Not that we're engendering or encouraging drug use, but we obviously don't want them to overdose, and we don't want them to actually, get HIV if they don't have HIV already. Obviously, this is in communication with the SUDS provider. Carrie and I do prescribe this in the telehealth setting. I think the fellow clinic, we really try to work on primary care and mental health, but just know it's there if it comes up, and then mental health and SUDS can also prescribe, but it does exist. Yes, and that's ending the HIV epidemic. So these are some resources for you. We have the treatment guidelines, of course, which are excellent. They have the brief version and the long version. And Dr. Pardo will be working through with you with the HIV national curriculum, which is gold. It is amazing. It's well written, and they have wonderful slides. They do an excellent job. The guidelines recommendation for the CDC. And then the VA has an HIV home. They have their own modified version of VA-specific resources. So I'll end it there. Thank you very much for your attention. I'll take any questions.